I'm Dr. Michela Guglieri. I'm a consultant neurologist and I work at the John Walter Muscular Dystrophy Research Center in Newcastle. I have a specific interest for Duchenne, and in Newcastle I'm leading the clinical research team, so I'm involved with the clinical trial. But obviously my first interest, and I think that is an essential step when you do clinical trials, is an interest for standard of care. So to guarantee that every single boy with Duchenne is provided with the best care available. The talk, I'm in this room now for 2 talks in a row. You don't need to stay for both of them, please. But the first talk is about corticosteroid in Duchenne. So it's a general introduction. I tried to keep, in a way, the presentation relatively short and to give plenty of time for question. I've done this presentation for a few years in Action Duchenne, and I think that this is really an opportunity to have an open discussion about any question that you can have regarding the topic of corticosteroid. And I hope to have an answer or to direct you to where an answer can be found if possible. At the same time, if you have anything that is not clear, I'm clearly from Newcastle, but not originally from Newcastle. I have a very strong Italian accent, so if something is not clear at any point, just try to move their hands and I can stop and ask. Now, technology. Yeah. So, first of all, I thought that although the title actually of the presentation is Steroid in Duchenne muscular dystrophy, but is management of steroid. But I think that we really need to first start about why do we use corticosteroid in Duchenne. And some of you might perfectly know, and I'm just saying something really boring and repetitive, but I think that is an introduction that will explain a few steps forward. First of all, we use a specific form of steroid, is a corticosteroid or glucocorticoid, which means that these two have been shown to be beneficial in Duchenne. It doesn't mean that any kind of steroid, and particularly anabolic steroid, will work in Duchenne. The idea, and has some implication, is all our body produce corticosteroid normally. So it's something that we normally have in our body. And in Duchenne, we replace and we give higher doses in order to have a specific action on the muscle. And the specific action that we want in a muscle is the anti-inflammatory. So we want to remove the inflammation. Corticosteroids are probably the best known drug and the whole use. So it has some advantages and some disadvantages, but it's a very old drug, so it's not perfect, but we relatively know it quite well. It has been used in several other conditions, but there is one difference, that I think that Duchenne is the only situation where we give so high doses of corticosteroid for so long period of time. So we are a little bit alone when we think about the long-term effect, especially in side effects profile on corticosteroid. And we can have a discussion with other specialties, but we are a little bit different in a way. What I want to show in this, probably was that there, is, I don't know if I have a pointer, but the reason why we use corticosteroid, as I mentioned, is to reduce the inflammation. This is the imaging of a muscle of a boy with Duchenne muscular dystrophy. The first one is actually an healthy boy, and the second and third one are a boy with a Duchenne muscular dystrophy. And you can see there are a lot of blue spots. That are the inflammation. That is what is quite active when the child is young, and is the one that the corticosteroid can control and change. I always pointed out that it's an exciting time for Duchenne muscular dystrophy, with a lot of treatment that are becoming some available or some tested in clinical trials. But at this point, corticosteroids are the only drug that is available for all boys with Duchenne muscular dystrophy. And there are several evidences that Duchenne can prolong the ability to walk over a certain period of time, but also there is nothing different between the muscle in the legs and the muscle in the arms. So if they work prolonged in ambulation, they've also shown that can maintain the upper limb function, so the arm function, for longer. They also have an effect on the respiratory muscle, so they will maintain the breathing function for longer. There are now more recent evidence that protect also from the development of heart problem, and definitely reduce the frequency of scoliosis, so of the curve in the spine. There are 2 types of corticosteroid that we use in Duchenne. One is prednisone and the other one is the deflazacort. The difference between the two, prednisone is available in tablets and in liquid solution. is available everywhere and is really cheap. It's the one that has always been used. So it's the one that I always said is a part that is cheaper and is one of the reasons why we tend worldwide to prescribe it. But it's also that we know it better. The Flazacort is a little bit more recent. It's still a quite old medicine in a way. It's available only in tablets and is not available in all countries. It's more expensive, so there are some clinics that might struggle to prescribe it. It's not really the case in the UK, but when we think about worldwide. Corticosteroid, you might have, all today actually, I understand it has been a full day about the updated standard of care. So in January this year, we have an update of the best care that should be provided to all boys with Duchenne and young men with Duchenne muscular dystrophy. And corticosteroids were in the previous standard of care as a recommended treatment and are still confirmed. So the new standard of care confirmed that corticosteroids should be prescribed or at least discussed with any boy who is diagnosed today. And this is explained and described in the family guide that I always wanted to put it as, because it's the end of the day today, and I think that is a big message to say, as there are information there, have been produced for a family, have a read, ask a question to the clinician if something is not clear. Are guidelines and will help you to go through this. And corticosteroids are really well described, both in the scientific paper and in the family guide. I always point to this slide because it's interesting in a way. So the first time that corticosteroids were used in Duchenne was 1974, the first publication. It was a small group and they reported that there were some benefit. In the UK, we've been using corticosteroids for now, I thought for 15, 20 years, but probably is even longer. And for the standard of, so from 2010, with the publication of the first care recommendation for Duchenne, became a recommended treatment. There are, since then, so since 1974, there are several publications to show why do we prescribe corticosteroid. So there are evidences that corticosteroid has an impact on muscle strength and muscle function, and as I said at the beginning, also to postpone breathing problem and heart problems. What these publications, to summarize, show is that if you start corticosteroid at the right time, the boys can really improve, so they can reach new abilities. So quite often is that boys with Duchenne might not get the ability to hop or might not reach the ability to jump. And when you start corticosteroid, you can clearly see that they reach new skills. They maintain the muscle strength for longer, and as I mentioned, this means that they might walk. There are controversial data, but they prolong the ability to walk between 3 and 5 years. But also now there are emerging data that they remain functional in terms of the upper limb for a longer period of time. I always want to mention that there is about a group of boys that unfortunately do not respond to corticosteroid. And it's very difficult to say, but there's reported between 1% and 2%. And we don't really know why, but is a group that need to be considered, because it's possible that even if we start, you don't see any response. As I mentioned, this is a publication that has been, I think that I wanted to mention, not to make you realize about numbers, but it's a very large study, it's the Synergy study, that is a quite large group of more than 300 boys with Duchenne that has been followed up for 10 years. And they really show that they, because are in different countries, they are able really to compare boys that are treated with corticosteroid and boys that are not treated with corticosteroid. And all of these, if you can see, the red line is the boys on corticosteroid and the blue line is the one not on corticosteroid. And when you see the drop is the loss of function, and there are different points. It is how quickly they get up from the floor, or when did they lose the ability to walk. And you can see that in terms of age, the red line is always on the left, which means that the one on steroid lose the ability to perform tasks later than the one that have never been treated with corticosteroid. And all of these data regarding the legs, but also for the older boys is also to maintain the arm function and the respiratory function. So again, the red line show you that they maintain the ability to reach their mouth with the arm for a longer period of time. But as I mentioned, this is an introduction about why do we give corticosteroid. But the topic today of the talk was about the management, so I want to focus on that. And I think that is an important component, because if you look at the standard of care, and all the presentation that has been given today, a lot of the management of Duchenne that we do today is actually managing side effects of corticosteroid. And we can have a discussion at the end about, is it worth? For me, the presentation that I've done so far, why do we prescribe corticosteroid? The benefit that we see on boys treated with corticosteroid are worth the fact that the majority of the care now is around managing corticosteroid side effects. But we can have a discussion about that. A few points, and then actually I start with the three big questions, is that every family asks me, and for which probably I still do not have a specific or precise answer. When shall we start steroid? Because if you go through the country, everyone starts at a different age. And there isn't really worldwide or in the UK a clear agreement. And you will really struggle to find a doctor that say you must start corticosteroid by the age of 4, or by the age of 4.5, or by the age of 6. But there are general information. We always said that corticosteroid should start in the plateau phase. We generally say that boys with Duchenne might start walking a little bit later, might be a little bit slower in learning motor skills. So even if they start walking before the age of 18 months, they are not as agile or as confident in running or doing the stairs. But there is an age when they still gain function, so they still improve. At that point, we always recommend to say, let them improve, let them grow without any intervention. Let's see when they can reach their maximum skill. There is then a phase when they plateau, so they don't lose any skill, they do not lose any muscle strength, but they do not gain anything. So it's the plateau phase, and then is when they start struggling. So corticosteroid should be started in the plateau phase. It's easy to say, but then it's very difficult to identify when it is. And I always have this question in clinic to say, we do an assessment in clinic, as usually is the North Star that you probably are all familiar with. And the North Star show that is absolutely a plateau. And the parents tell me he struggle more with the stairs. So where do you stand? Or vice versa. I see a deterioration on the North Star, so on my assessment, but the parents say, actually, he's getting better and getting in and up and down the stairs because he's more confident. So that is a little bit a descriptive recommendation, but then it is a discussion that has to involve both the family and the clinician. There are some evidence that very early treated, there is one study actually from an Italian group, and is a quite historical group, that if you start corticosteroid before the age of 4, you have a better outcome. This means that the one that started early, they are able to walk for a longer period of time, and the respiratory breathing function is maintained for longer. There's only one study. It is a retrospective, so there are some limitation in that, and is not a large population. And one of the concerns for which I don't think that we have an agreement is that obviously if you start early, you will also see side effects earlier. And when we are recommending to continue corticosteroid for a very long period of time, you might not want to see side effects too early. But it's something that is worth to be investigated. There is currently a study in US to try to see the effect on corticosteroids started before the age of 4, and hopefully the results will help us to address this concern. But as I mentioned, it's always a balance, pro and con, side effects and benefit. There are more than one publication now that actually show that the problem is not to start too late. So it's an artificial, started treatment before the age of 7. But what we see is that if you start corticosteroid when the boy is already deteriorating in his function, it's very difficult to reverse that point. So you might start to, if he's declining, he might decline a little bit slower when you start corticosteroid, but they will not regain function. When if you start early, you maintain him on a higher function. Does it make any sense? So I always said that starting too late might be dangerous. And I reinforce this point because it's something that I always say in clinic. If we start too late and the boy is getting worse, you start corticosteroid and you do not see any response, you don't really know if it's because you started late and you start seeing the side effects, or it's because it's not a responder. So it's something that then is then difficult to manage benefit and side effects. Why? Is the concept of the inflammation. So this is a muscle biopsy of a boy with Duchenne in different stages. So But the first one is still the normal one, and then we have an inflammation. So when they are young children with Duchenne, they have a lot of inflammation. This is what the corticosteroid is supposed to control. After that, when there is a chronic inflammation, is when the muscle is replaced by fat. It's connective tissue, but at the end of the day, fat is something that doesn't contract, doesn't give you strength. If there is fat, the corticosteroid doesn't do much. So the point is that if you start too late, the impact will be less, and there is a clinical reason for that. Second big question, and then is a big question about what shall we start? All of you probably have heard, shall we start prednisone? Shall we start the Flazacort? Shall I start daily? Shall I start intermittent? Shall I start high doses at weekend? I don't have this answer. I want to be honest with you, and at the moment, probably it depends on where you live and what the clinician that you are under the care is more familiar and confident with. Is not always related to your boy. There is still a value of that, because if I'm have more experience with one regime, means also that I'm better in managing that regime than other, and I'm better knowing how to deal with side effects. So it's not wrong that is the clinician experience to dictate that, but I would like that one day we will know which one is the best one or which one is the best for a specific boy. At the moment, except for extreme cases, such as if you have a boy with several behavioral problems, you might prefer to start with the Flazacort and then with the prednisone. If you have a boy who already struggles in terms of weight control and management, you might start with the Flazacort and not with prednisone. Otherwise, it's really geographical distribution. And as I said, the regime is really a mess here. So depending on where you are seen, you will receive a different regime. In general, I think that is logical. So if you take steroid daily, you have more effect, so more benefit, but more side effects than if you start steroid on intermittent regime, 10 days on, for example. So that is absolutely obvious. It's also true that it's very difficult because everybody responds in a different way, and especially regarding side effects, everybody shows side effects in a different way. But as a general rule, that is what we see. I think that there is one thing, alternate days, there is two old studies showing that is less effective, but is not associated with less side effects, so is not one of our recommendations to have alternate day regime. In general, what is better between the Flazacort and prednisone? The Flazacort surely is associated with less weight gain. I feel confident in that, say that. And there's a higher incidence of development of cataracts, so problem with your eyes. Everything else, I think, that is a little bit less clear. Someone said that the Flazacort is associated with less behavioral problems, but I think that there is no strong evidence of that. Someone now more recently is showing that the Flazacort might have a worse impact on bone, so increase the risk of fracture more than prednisone. But we need to be careful to make any conclusion on that because usually the Flazacort is associated with less weight gain, we tend to give higher doses or maintain higher doses of the Flazacort compared to prednisone. So the effect that we see in terms of the risk of fracture might be related to the dose and not to the drug itself. I know that this morning was already discussed a little bit the 4DMD study, and I just want to put some clarification. And also, I don't know if there is anyone in this room that is taking part in the 4DMD study and is a way to say thank you, because it's a big, long study which has required a lot of commitment from the participating families. The 4DMD study is a randomized, double-blind, parallel group study which compare 3 corticosteroid regimes: is daily prednisone, daily the Flazacort, and intermittent 10 days on, 10 days off of prednisone. We have recruited 200 boys, so divided in these 3 groups, and we've monitored them for 3 years. The last patient last visit will be at the end of 2019, and hopefully by then we will have a little bit of better understanding how can we compare these 3 regimes in the long term. The study, however, is designed for boys that were steroid naive when we started, so 4 to 7 year olds. So the idea was to prescribe corticosteroid as we do in clinic, so before the age of 7. And they have been monitored for 3 to 5 years. So the study will not at this stage tell us much about the use of corticosteroid in older patients. There is the idea that this boy will be continued to be monitored in long term, but these are parallel studies. So for now, it's just to give us an idea which corticosteroid should we start, or a better understanding of the differences between these different regimes. I want always to point it out that the decision about which corticosteroid start and which regime is always something that depends on the clinician and depend of the family, and there is always an open discussion because everybody has to be provided with information. At the same time, one point that I always make with our family is that if we start of the right dose. So we know that the correct dose is prednisone 0.75 milligrams per kilo, which is the equivalent of the Flasacor 0.9 milligrams per kilo. And these are equivalent. My concern is that we know that low doses of corticosteroids, so less than 0.3 of prednisone, do not do anything, but they can still give side effects, but no benefit. And higher doses, up to 1 milligrams, do not have any difference in terms of effect compared to 0.75, but are associated with more side effects. So we know that that is the correct dose as being tried in clinical trial. My concern is that if we start in lower doses because I want to see less side effects, if you don't respond, if the boy doesn't respond or doesn't respond as much as I would like to, I will never know if it's because I'm not giving the right dose or it's because he's not a good responder. And moving from there, then you start increasing the dose, but it's actually, if he's a non-responder, increasing the dose will give all the side effects, but no benefit. So it's better to start with the right dose. I know that I gave you the best chance, and from then we move on. So that is my recommendation. It's a personal recommendation, but I think that is an important point. For everything, from which regime, when to start, how do we manage, how do we change the dose, steroid is always a balance between benefit and side effects. We do this with any single drug that we take. There is no drug, it's a lie when the people tell you, oh, this drug does not have any side effects. It doesn't exist. They have side effects. But it's always a balance. If you have a high benefit, you accept more side effects. You have a little benefit, you accept less side effects. And you balance these two of them. And this is what we do in steroid all the time. The problem with corticosteroid is that we have a lot of side effects. And it's a very, very long list, and we'll go through this. And I'm not here, I'm a big fan of steroid. I prescribe personally corticosteroid to any Duchenne I see in clinic, but I'm not minimize the side effects. So I know that the side effects are significant and need to be monitored. We can't just ignore them. So one big problem is the behavior. What we see actually with the behavior, I think that is an important component because there are a few boys, and I think that in my experience are really a very small group, that you start corticosteroid and after a couple of weeks, about 2 to 6 weeks, then family come back and say, he's not my boy anymore. I don't recognize this boy, it's a completely different person. This is a group of boys that do not tolerate steroid. It's really an acute adverse reaction. And in most of these cases, we need to stop because you still want to be able to interact with your boy. Then there is the majority of the boys with Duchenne that has this behavioral problem. That means that they tend to be extreme in reaction they already have. So boys who already have some behavioral issues, the behavioral issues become more evident and more prominent. Or boys that are anyway age 4 and age 5 and they have big tantrum, and the tantrum becomes something massive and very difficult to control. So is an exacerbation of already present behavioral problem. This is the most frequent one. In the majority of the cases, they resolve with time. So as soon as you wait a little bit, the body gets used to it, but not always. I highly recommend these two reading about management of behavioral problem with Duchenne, and they specifically the one from Parent Project, the first one in red, has been written by Josh Hendrickson, that is a psychologist in Germany. And I have to say that I heard one of his speech once and was the best advice in behavioral management for any child with or without corticosteroid. And tell you a little bit about how do you manage this huge tantrum, how do you manage this big explosion of behavior, and I found it very helpful. Second big concern is regarding the weight. that is a big issue. Corticosteroid increase the appetite and increase the weight. In some of the boys, is an effect that you see straight away. In other, you see after a few years. But I would say that sooner or later, all of them will have a problem in terms of weight. And obviously, because the weight impact the muscle function is an important component. How do you first manage that? I think that is important, the diet and the portion. I know that is very difficult, and I have different family, and I perfectly understand, but I heard family to say, yes, but he loves his food, he already struggled with his mobility, can't play football with his friend, give you one satisfaction, that is food. And I understand, as a mother, you understand that, it's easy. But in the long term, it's something that really doesn't good is good. Or other situations say, we are absolutely careful with the diet. He just eats 1 packet of crisps a day. These are all things that can definitely improve. So be careful about the diet and be careful about the portion. Sometimes it's a simple thing I advise, buy smaller plates. Just the size of the plate. If you have a smaller one, you give a smaller portion, it's natural. Our little thing, and I always say at the same time to the boys that even if they stop eating, they will struggle to lose weight. So it's a balance. I'm not saying that you're all having a bad diet or the portion are too big. Are the corticosteroid, and we are just trying to manage. I put one slide. I don't know, have been already discussed today in the endocrine group? The metformin? No. I put it down because it's a little bit of provocative things, but I think that everybody recently is talking about the use of metformin. There was a few publications that I mentioned here are all scientific publications, don't be bothered to, but it show between animal models and actually patients with Duchenne that has been treated with metformin and L-citrulline and has an improvement of muscle strength and function. We recently have a call with the North Star team, that is the North Star consortium, that are all the clinicians that treat Duchenne boys in the UK, children. And we agreed that actually there are no strong evidences that metformin is improving muscle strength and function. There is only one study that is small, is open label, doesn't have a control, that shows some impact. And the reason is because the original study in the mouse seems that reduce fibrosis, so there is a concept, but there are no evidence at the moment that metformin can really improve muscle strength and function. It doesn't mean that there is not worth to further investigate it. So we might need additional trial to better understand the impact of metformin and L-citrulline on muscle strength and function. But at the moment, there is no recommendation. At the same time, I think that I put it here in together with the steroid and the weight, because metformin is very well known for treating diabetes and obesity. And there is probably a window also in Duchenne, because corticosteroid can induce diabetes, can induce obesity, and metformin might be considered in boys that have overweight and they have an insulin resistance. But has to be, for the evidence that we have at the moment, has to be on a case by case. And I think that is important to highlight it. I will mention also in the transition, because again, everything comes with side effects. And the balance depends sometimes on a single case or on the age of the patient. But I'm happy to further discuss this later. Other massive side effects, I'm sure that this was discussed at the workshop on endocrine with Jared this morning, is about the possible risk of fractures and increase the risk of long bone fracture, make the bone be more fragile. So it means that even if the boy, usually, if a person is not on corticosteroid, if we fall from our height, so if we just fall when we are walking, we should not break our legs or our bones. The only reason is when it's a traumatic fracture, so you fall on a high speed or from a height that is higher than your own height. With corticosteroid, the bone is fragile, so it can break even if the boy falls just from standing and fall down. There is two risks. One is the legs, long bone, so generally the legs, and the vertebra. 2 points with the legs, obviously, is the higher risk, because if you break a leg, there is always the concern about the impact on mobility. Will they ever be able to walk again? And the second one is regarding the vertebral fracture, and we know that now there is a high risk of vertebral fracture that actually do not have any symptoms. So if I have a vertebral fracture, I will be in pain and lie in bed screaming. Boys with Duchenne seems that they have vertebral fracture, and because it's not an acute event, they complain about a little bit of back pain for a couple of days, and then they are absolutely fine. But if you do an X-ray, you see the vertebral fracture. And when you have one, there is a higher risk that there are multiple. So there is intervention. So vitamin D, at the moment, is still recommended as part of the care recommendation. Regarding the calcium intake, we usually recommend to take it with a diet. It's better a glass of milk or cheese instead of the tablet. And the tablet is disgusting. Try it before giving to your child and then decide if it's better a glass of milk. If there is any evidence of fracture, treatment with biphosphonate should be recommended. There are no currently indications that biphosphonate should be prescribed prophylactically, but I guess that this has been already discussed. Other side effects. I think that short stature and delayed puberty are massive and are becoming more and more evident. And one point that I want to make is that when we become better in managing the side effects, we discover there is another one that is important, that probably before was denied because there was something else that was more severe. And it's something that we are learning, but in a way tell us that we are improving in managing. But I have more and more patients that come to me very upset because they are small. And there is two things. In general, when they are smaller, their muscle function is better, so they are more agile. That is something that we see now. I mean, very tall people usually are not very agile and good in sports. So it's better for the boys with Duchenne to remain small, but it's easy for me to say. And I always said an Italian thing that the good wine stays in little bottles, but the boys do not appreciate that. And usually it's something that really upsets them. And I have to say, there is nothing that we can really do. Is an effect of corticosteroid. In general, even before starting corticosteroid, we have seen that the boys with Duchenne tend to be smaller than their peers, but obviously corticosteroid doesn't help with that. There is a lot of discussion about growth hormones, but if you do not have a growth hormone deficiency, it will not impact your final height or will impact really minimally, but you will have all the side effects. Even if you stop corticosteroid, probably you gain a little bit of a height, but depend a little bit when you stop corticosteroid in order to increase the height. And it is very difficult to make the decision to stop steroid because the boy is small, but you know that if you stop at that time, they will dramatically lose the function. But we also know that steroid delay the puberty, and for this there is treatment that is giving them testosterone. It's not a magic drug because it doesn't induce a natural puberty, but definitely help in terms of appearance and definitely help a little bit also with growth. When we go through puberty, boys tend to grow, and the same can happen to the Duchenne boys, although it's not as massive as we see in healthy young men. But I think that there is definitely more and more indication that every boy with Duchenne after the age of 12 should be assessed for delayed puberty and treated accordingly. Immunosuppression is not something that we really see, but just a couple of points. Everyone should receive the annual flu jab, but has to be the injection. The nasal spray is a live vaccine and therefore put them at risk. So it's one important point. Generally, they should not receive live vaccine. So if they need any vaccination, you always need to ask if it's a live vaccine or is an inactive vaccine, and they should always receive the inactive vaccine. And before starting steroid, they should all receive the chickenpox immunization, just because if they have a reduced immune system and they develop chickenpox, the chickenpox may be more severe. For the gastrointestinal, some of the boys on steroid for long term, they complain about pain in their tummy, and this really, in theory, is a high tummy. Usually a child, especially when they're 4 and 5, they have tummy pain, and it's very difficult to understand is it abdomen, is gastric, is just abdominal pain. But there is a very high risk of gastritis and ulcer, and therefore, if they complain about symptoms, they should be treated with a gastroprotection, that is a lansoprazole, omeprazole, name like that. And generally, boys with Duchenne on steroids should not receive ibuprofen, that is most common as non-steroidal anti-inflammatory. It doesn't mean that it's a no-go at all. If they break legs and they have it in pain, they can take ibuprofen, but always have the consideration that they might develop a problem with the stomach. So if they need to take ibuprofen for a few days consecutively, I would co-prescribe the omeprazole or lansoprazole to protect their stomach. Do not stop corticosteroids suddenly, never. And the reason is what I said at the beginning, that our body produces steroid naturally. And if they take steroid, they stop producing corticosteroid. And therefore, if you stop suddenly, their body remains with zero steroid. The steroid is very useful to maintain our heart rate, our breathing. So a drop in the steroid, a sudden drop in the steroid can be really life-threatening. So it's something that we need to be very careful. The point is that you might forget the tablet. Give them as soon as you realize that. If they vomit, they can't take their tablet for more than 24 hours, they should receive steroid in a different way. That is usually IV. But also, if the boy is unwell, so is vomiting, is really ill, they should receive higher doses of corticosteroid to help them go through, to maintain the heart rate and their breathing. So always, if they don't take corticosteroid or they are really ill, ask for a medical advice about it. In general, I think the most important thing is that if they are on corticosteroid, they need to be seen, because the management of all of these side effects required medical advice and monitoring. And therefore, it is important that they are provided with an appointment every 6 months in order to monitor that. One point about when should we stop steroids, so the older one, because the idea was for several years we stopped corticosteroid when the boys lose the ability to walk. Now, both the standard of care and general practice and the consensus in the UK is that corticosteroid should still be continued after the loss of ambulation. And this is because there is no difference between the leg muscle and the arm muscle. So the effect that we see in prolonging the ambulation, we also see the effect in maintaining the arm function. And we also see that to protect their breathing, so allow their breathing to be in a better shape for longer periods of time, and slow down the development and the progression of the cardiomyopathy. So these are all benefits that continue even when they lose the ability to walk. Obviously, is a balance, because when they become older, the weight might become a concern, and therefore we want to balance and maybe play a little bit with the dosing and reduce the dose compared to the original 0.75 milligrams per kilo. There is a point when the side effects overweight the benefit, and then we decide to stop corticosteroid. But this is on a case-by-case and has to be done at the right time. There are, I think, you will hear more tomorrow about this, but it's interesting, and particularly I have to say that I'm biased here because the study chair of the second, so the Reverogen and vamorolone study, so I have a conflict of interest here, and I will present it tomorrow as representative of as a study chair, so there is a conflict. But my point today is that there is research going on to try to produce a better steroid. So we know that there is a drug that is really good for the efficacy, but has a lot of side effects. So for my perspective, I don't care if it will be vamorolone produced by Reverogen or CAT1001-004 produced by Catabasis, but if anyone can produce a steroid that maintains the efficacy and reduce the side effects profile, probably this would be a good direction to go. Both of them maintain the anti-inflammatory drug, and from early studies show that there are less side effects. And the idea is that both of them are in a good stage because they are developing a phase 3 and a phase 2b, so are the longer placebo-controlled study, which are starting now with both companies worldwide and in the UK to try to understand whether these two options could replace corticosteroid in the future. And the idea is that if they work in the population that they are targeting, that is the 4 to 7, so the one where we know which effect to expect, potentially then can be definitely expanded to everyone who is still taking corticosteroid. So just to sum up, my main point is that are part of the standard of care, and I'm not saying that should be prescribed to everyone, but should be discussed with every single family. I think that there are no doubt about the benefit, but there are also a lot of side effects, and the management of the side effects is probably the majority of the care that we now provide to Duchenne boys. One point is that at the moment, the majority of clinical trials ask the boys to be on stable corticosteroid for at least 6 months, and they are becoming more restrictive in terms of regime. So the point is that they want to have an homogeneous population, and the problem is that if you start steroid while you are in a trial, you will see a benefit that will be due probably to the steroid and not to the effect of the drug. And therefore, that is when is an exclusion criteria for most of the trials. And hopefully the next generation of steroid will come soon. And I complete here, and I think that I still have 10 minutes. Yeah, so for any question, yeah. I have to say, it's my answer, okay, it's my personal opinion. For some of the medication, there have been clinical, for example, for coenzyme Q10, there's been clinical trial, not specifically for Duchenne, but in several muscle conditions, including Duchenne. And the clinical trial failed to show any benefit, so they did not show any improvement in terms of muscle strength and function. This doesn't mean that the patient, because we're adult and children treated, did not report that they feel more energetic or feel that they could keep going for better. They felt better generally. But this could not be quantified in any way on the assessment. So I'm a strong believer in clinical trials, but it means that we need to have evidence and things work. Then we found the balance, because again, it's side effects and benefit and side effects, and most of these drugs do not have huge side effects. But for example, for coenzyme Q10, it's quite heavy for your kidney. So giving coenzyme Q10 to a very young boy, you actually can impact their kidney function. And for me, in that case, the potential side effects based on the evidence of benefit are against taking it. In the older one, I would never prescribe it because I don't think that there is the clinical indication, but a personal benefit can be a personal benefit. Sometimes I think it's the placebo effect, but at the end of the day, we want the boys to feel better. So I tell everyone in trial, I don't care if it's the drug in trial or it's the placebo effect, it feels better and it's good, keep going in this direction. But there is a balance that I think that we all will need to cope. So I'm not in favor, but I'm not absolutely against. But two major points that I would like to make, three probably, is be careful about the number of medication. So all of us, when we take tablets, feel ill. So, and this doesn't exclude boys with Duchenne. They already take a lot of tablets. They take the steroid. One point they start with the heart medication. Then point they start with the vitamin D. And some point they start with the testosterone. There is a lot that we are doing. And sometimes starting taking 20 tablets in the morning is annoying. And so keep an eye on that and play your card at the right time. I don't want a boy to be absolutely annoyed by taking tablets when he actually needs carton medication. And you need to discuss about, oh, actually this one you really need it. So it's always a balance. The second important point is be careful in clinical trials. So the majority of the clinical, if you want to take part in a clinical trial, some of these supplements might not be allowed for protocol. Usually, they always ask a period of cleaning, so you just need to stop 6 weeks before or 4 weeks before starting. So it's not, or if you are, you will never be able to take part in clinical trial. But it's something that needs to be taken into consideration. And the third thing is that I'm not particularly in favor, but I'm not particularly against. But one point is, please, please, please do not hide medication to your clinician. This is a huge problem that we have. I know that because people think, oh, the clinician disagreed for me to take Metformin, because I said that. And therefore, I take Metformin, but I don't tell the clinician. But this becomes, for two problems, that does not allow us to monitor side effects, when actually, why not? We are doing it. But also is to allow us to monitor potential benefits. So ideally, we would like a clinical trial for everything, but sometimes we can't. But if you tell me that you are on Metformin, we collect data on the North Star, we collect data. And one point we will be able to say, actually, on the North Star, there are 50 boys on Metformin. It's not controlled, it's not a perfect study, but all of them are really doing really well with the weight. So maybe it's worth to continue. If I don't know, I will never be able to make any conclusion.
One more quickly. What about tamoxifen?
Sorry?
Tamoxifen.
Yeah, there is a clinical trial planned. With tamoxifen, I think that this is a little bit different. Tamoxifen is also one of the drugs that is not true, that is free of side effects. There are evidences that has a potential benefit in terms of muscle strength and function, but I think that is one of the drugs that really need to be tested in clinical trials to balance benefit and side effects. So for that one, I would say be careful. But again, I also know that a lot of boys are on tamoxifen. Tell us. I mean, if someone tells me that he's on tamoxifen, it's fine. I can say it's not my recommendation, but we don't do a lot of things that are not recommended by doctor. We, not the boys. Yes, I mean, I think that, no, I wouldn't by myself. I mean, I think that is a request of the boy. And when you go to puberty, it's really a request of the boy that actually is a young man. And is a very difficult call. for one perspective, I think the problem is that it's true that we have a treatment to induce, artificially induce puberty. It's true that it's not a perfect treatment. So it's not, if you go through puberty naturally or you go through puberty with testosterone, it's not exactly the same. And therefore, you have some effects that are equivalent and other that actually are better if you go through puberty naturally. The problem is that when you want to induce puberty, it's between the age or around the age of 14, 16, let's say, because until the age of 14, you can wait, even they are on steroid, they might still go through puberty. I do apologize, I don't see your face. Yeah. But you are between the age of 14 and 16. That is the age when quite often is a little bit a tricky age, because it's when they start really struggling more in terms of function. And if you made that decision at that point, you induce puberty, but you will see an effect on mobility and potentially on respiratory function. And therefore, I want the young man to make an informed decision on that. So it's a very difficult call. I've not done it so far. I've never arrived at the point that someone told me yes. I usually said, let's try with testosterone, and I've not had anyone wanted to stop because of the puberty. I have boys who want to stop because of the growth. And this is even more difficult because even if I stop, I do not expect them to grow as much as they are asking me to.
Okay, thanks.
Okay, I've been involved in the 4DMD and it's been, the longest study ever. So I promise that when the result will be available, I will come to this meeting and I will present them. But the point is, the last patient, last visit, so will be in October next year, 2019. But then there is a window, so potentially can be postponed until December 2019. From there, just to give you clear timelines, we have planned for 3 months, and is optimistic, but is our commitment, to have 3 months to clean the data and lock the database. And at that point, which will be March 2020, we collect the data and we analyze them. So I would say that it will not be available until second half of 2020. So I would say that if the 4DMD study will show that one regime is clearly better than the other, there is definitely the intention to disseminate the information as wide as we can. And although it's not so easy to move boys from the Flazacort to prednisone daily, you can do it from one day to another. The problem is the intermittent, because the one on daily have an adrenal suppression, and if you stop for 10 days, they can have an adrenal crisis. But there is the way to do it. There is definitely the way to do it. And if that is the best regime, that is where we go. I have a little bit of feeling that the 4DMD will not give us a black and white answer. It's more that we will know better and we will be able to discuss with each family and each single patient on a case-to-case, this would be your best regime. And so it will be a little bit more personalized.
Thank you.
It's very... I don't think that we have done... We've done in Newcastle, actually, a clinical trial with testosterone systematically. And therefore, we are collecting also growth data. And we have completed it. The results should be published within the next 6 months, so hopefully I will have a better idea, although it was only limited to 15 boys, young men, so is a little bit. For what we see, it really depends. Some of them grow more than others. For my experience, in our clinic, what I see is between 3 and 5 centimeters in the first year of treatment. But then it's not that it's 3 to 5 centimeters every year. So you have the grow when you induce puberty, and then continue for the first couple of years and then slow down. But quite often when we talk with the boys, they said, I want to become as tall as my dad. And you think, that will not be. Testosterone is not given for growth. Testosterone is to give from puberty, and growth is a secondary effect. But that is what we see. Depend a little bit on timelines. I see that it's not completely reversible, but they definitely lose weight when you stop steroid. But depend a little bit when you stop steroid and for how long later you want to see an effect. Quite often it's not an immediate effect, because usually if you stop steroid means that also they are losing function, so they move less and they lose and they don't use so many calories, and therefore is not the best situation in order to lose weight. So it's not only the steroid, but it's a combination of the two. So you can see an effect on the weight, but it's not as dramatic as in an active boy. The second thing that actually we need to be careful is that older boys, especially not on steroid, tend to lose weight anyway. And the reason of that is not the effect of steroid, but is a little bit of lack of appetite sometimes if the respiratory function is not really good and is not picked up at the right time. Quite often the problem is also that when they become less mobile, eating takes longer, and even if you do not notice and they don't notice, they actually eat less. So in the older one, we need actually to be careful about the loss of weight more than the weight gain, if it makes sense. In general, we said there is a study showing that if you go, we prescribe usually 0.75 milligrams per kilo. And there is a study showing that if you go up to 1 milligrams per kilo, you see more side effects, but you don't see more benefit.
No, I mean if the...
The cutoff, yeah, we usually do not prescribe more than 30 milligrams per day of prednisone and 36 milligrams of deflazacort.
Thank you.
That is the maximum.